I just wanted to open it when we have a piece and make a background. I've,
name is Dr. Samora Michelle. My name is Samora Michelle, and I will be your moderator today. I'm a medical doctor working in the Healthcare Quality of Kenya division of Kenyatta National Hospital. So this is the third webinar in the Patient Safety Day series. We had started by looking at the role of patients and family in improving diagnostic safety last week, and we also had one on Kenya's roadmap to implementing the WHO Global Patient Safety Action Plan. And today we are going to hear from a patient. We have one of our panelists, who's Mary Oyeke. She is a patient advocate and a cancer warrior, and we're very happy to have you on board today, Mary, to be able to listen to you share your story and learn from that. Our other panelist is Dr. Lydia Okutoi. She is the director of the Healthcare Quality Division in Kenyatta National Hospital. She's also the president of the Society of Quality Healthcare in Kenya and a co-founder of AQUIRE, which is the African Consortium for Quality Improvement Research in Frontline Healthcare. So we're very happy to have you all here, and we're looking forward to having an engaging discussion. So we're going to talk about getting it right and making it safe, which is the slogan for this year's Patient Safety Day, which we celebrated on Tuesday, the 17th of September. Yes. So I'll hand over the floor to Mary. We're going to hear from Mary first, and then after that, we're going to hear from Dr. Okutoi, after which we're going to go into a Q&A session. If you have any concerns, kindly put them in the chat box or in the question and answer section. Thank you. So Mary, welcome. Mary, you can go ahead and unmute so that
Can you hear me?
you. Yes, that's great. That's great.
Okay, good afternoon, everyone.
Good afternoon.
I would really just like to appreciate being invited to speak my truth and to tell my story in the hopes that it will help somebody, it will help many people, it will make an impact in the lives of those like me who are going through cancer. So I will try to be brief. Actually, yes, I already wrote my story. My sister challenged me to keep a journal of my story, and that journal ended up being 15 pages of a story, which I really would love to get published. But anyway, we will cross that bridge when we get there. Okay, so I'll just get into it. I will not talk too much about the other things. So I was given pointers to focus on, so I will go down those pointers, and then if there are questions, they can come later. Now, symptoms and how the journey started for me. So the symptom was actually a lump that was in my left breast that was hard and didn't move. So from time to time, I would carry out breast examinations, like you read and you're encouraged to do so. And I always love to read widely. And since I have a family that is genetically prone to cancer, that was a concern for me. But one thing we need to say is that not all lumps are cancerous. So that needs to go out there. So we also don't panic. If you find a lump, it doesn't mean that it is cancerous. So that is how I found out that there was a lump. Now, when I started experiencing it, so I will give a little backstory. My mother died suddenly in October of 2018. And then she was my best friend. So there was a lot of grief going on in there. So I was to get a job early 2019, which would have changed my life. But then COVID happened. So that job didn't happen as I had hoped. By the end of 2020, the lump had significantly grown. My stress levels were crazy, and I was keeping it all bottled inside because I had to put up brave face, especially for my children. For half a year, I felt it. But then I kept saying, okay, this thing needs to go away because I didn't have a job. See, COVID has happened, and I don't have money because COVID has happened. So I just kept saying, no, it'll go. Then October, Breast Cancer Awareness Month, I was like, there's no way I'm going to make a line with 800 other Watus just to get this thing checked. I was just like, no. So when the under of my arm started to swell is when I thought, okay, now this needs to get looked at. So I went to Iran Medical Center because it was my clinic of choice through NHIF. And the general surgeon, the GP that I saw, and the specialists that were very upset with me for leaving it. I lied 4 months, but it had been longer than that. But anyway, I mean, what would I have done? So the surgeon conducted a biopsy and took the results to Lancet. And the results came back after 3 weeks. I had ductal carcinoma stage 2. So I went for the results, took them. My daughter Googled, and it was, yes, cancerous. The ductal carcinoma was cancerous. So what did we do? I took my family for a lunch, and we ate properly as we digested this information. And then I told my other two siblings, I was with my younger sibling. I told my other two siblings, and then we strategized on how we were going to pass on this information. It was very boom, 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 because I'm very organized generally. So it was upon my brother to tell dad, because I mean, dad had just lost his wife, and my other brother had died of cancer. So it was, very delicate for us. So my brother tasked dad, and the other sister now was to rally the troops to fundraise for me to be able to proceed with this journey. So that happened. I got the first tests done. And then now the tests are done, yes. So what happens after that? So the tests include an ultrasound, which I did initially, and then the ultrasound and the biopsy. Then I did a mammogram and a chest x-ray. So these are to determine several things which the doctors require when they're mapping out your treatment. So MRI also is required to know the stage. I mean, to check, not to know the stage, sorry, to check how far the growth has spread in your body. So the ultrasound and mammogram results were immediate. The biopsy, I had to wait for 3 weeks because unfortunately the results were lost. But anyway, they were found, and then they were not conclusive. So I had to do an immunohistochemistry. Even that was still not definitive. I still had to later on do another test called FISH, but spelled FSH, which would determine the exact hormone levels in my body. So I did for 2 weeks. I spent a little over 2 weeks walking around, shopping for the best place that I would be able to do my treatment. And, basically just in preparation for what I knew would not be an easy little journey ahead. So before treatment commences, one must have done a heart exam, liver, kidney, white and red blood cells, and other internal organ functional tests. So the heart exam is repeated only after you're through with your chemo, but the organs are tested the day before every chemo session. So one must prepare for that, and that is to determine whether your body, your internal organs can cope with the medicines, because the medicines are not gentle on the body. So we finished chemo. We have rested a little bit. Then we have gone to Kijabe. we have met the doctors in Kijabe, booked an appointment, had the operation done, checked out of hospital, come back home, rested again a little bit. Then we are ready for radiotherapy. So before radiotherapy, again, you must do tests. That's when you do the heart exam. That's when you do a CT scan. And then in the CT scan, they do what is called mapping, because they put markers on your body. It's like tattoos on your body that will show where the radio machine will, I don't know what the word is, sorry, but will burn so that the cancers don't spread. So I hope I'm clear. I don't know what the word is, sorry. So then you have the heart exam, you have another MRI before you start the radio, you have an MRI to determine whether you need to do more chemo or not. So then if you're okay, you proceed to radiotherapy. Now, radiotherapy is 25 sessions, 5 days a week until you're done. Now, this is, for me, was more intense than chemo, because chemo, you could get up, you could go to the washroom, you could talk, but with radio, because of the nature of the machine, you have to lie absolutely still. Now, I wish to point out that once you start chemo, start to learn the lyrics of your favorite songs, because this will come in very handy, as you will be called upon to sing any and every song in order for you to sort of focus on the song rather than on having to lie without moving even a hair on your body for however long this machine is rotating and on you. And then we are done with radio. So after radio, then the doctor calls you and you have a session on, okay, what happens after this? So for me, it was, I had to do, I had 17 injections of Herceptin, and then I had to take anastrozole. Now I'm on anastrozole for 5 years. I'm left with 2. I've done 4. I will explain that a little bit later. So now the next session is how I was engaged. How was I engaged? So my initial doctor was good, but he wanted to treat me, but he was a surgeon. So how he hoped to treat cancer as a surgeon, really, I am still baffled. But he was very nice, but no, I mean, he was not an oncologist. So I went to the second doctor, and my body just did not like him. I will not name him for obvious reasons. So here I would advise people to listen to their gut. Your gut speaks to you. You must listen to it at this point, because it can make or break you, literally. So because he was too insistent on me having a double mastectomy, even before he had carried out the test that would determine whether I needed the double mastectomy or not. So I, in consultation with my sisters who had been through this process, not my biological sisters, but sisters in the space, I then came across Dr. Mbogo, who I would just say was an absolute blessing. So the next section is, who walked the journey with me? What support system did I have? My brother, Dr. Josiah Oyeke, my auntie, Dr. Jennifer Oyeke, were my primary consultants through this process. I had my sister from another mister. She's called Penny, who's my nutritionist, and basically guided me on who to see, who not to see, where to go, where not to go. Then I have 3 sisters who are warriors before me. There's Tina, Stella, and Sada. So they were on hand to give me advice, to help me navigate, because really you're literally thrown in the deep end. Whether you know how to swim or not, that is not the point. So they walked with me, helped me what to do. I sat on the phone with Stella for a whole day before I made the decision to go to MP-SHA. So then there's my entire family, my maternal and paternal. everybody heard I was sick and everybody just jumped on board. How can they help? What can they do? There was major fundraising. They chipped in. I was really, yeah. So my sisterhood from the Kenya High School, who made sure that I had the initial money needed to do the tests, plus any monies that I needed after that. My former colleagues at UNICEF, friends that had made through the journey. I'm a very outgoing person, so I have a lot of friends that I've made along the way, including my University of Lesotho friends that some I have not seen since we were in varsity a long time ago, but they were there for me. And then the Ochola family, Dr. Sam Ochola and his offspring, absolutely wonderful. I mean, the list is endless. I could continue. There's so many friends, so many family members came through, just gave of themselves in terms of money, in terms of support, where I asked for a doctor's name, boom, it's available. I have a lot of medics in my family, so that also helped. But honestly, truly, my cup overflows until today. So how much I understood concerning my journey. I read up because Google does not close. The university is open. So I Googled where I could. I consulted with my family members who are in the medical field. Where necessary, Tina and Stella, my sister warriors, gave me a lot of support. I have a friend called Archie who she will give her information and she looks for solutions. Emotions we'll deal with badai. So, she really just helped guide through this process. So I understood from that aspect of this is what to expect, this is what we need. And then I again went to hospitals, found out information, and then I went to Dr. Mbogo. Then I ended up at the HCCG, that's the cancer center within MPSHA, and Dr. Mbogo provided the information where there was gaps because the other people didn't know the medical bit. So I sat with Dr. Mbogo and he walked me through what would be expected in terms of the journey, what to expect in terms of health outcomes and everything. Dr. Mbogo, I don't know. Anyway, so then we start. He sends me upstairs. I book for chemo and I start chemo. So now I walk upstairs and I find the chemo center. Everyone is just warm. They're family. They're very nice. Everyone has everyone's processes on their fingertips. And I thought, why else would I go? Why would I go anywhere else, really? So I decided that place was it. I made my appointment. Dr. Mbogo literally made my journey a breeze until some people were like, is Mary really sick? Because she doesn't look sick. But it was because anytime I needed to talk to Dr. Mbogo, he was available for me. Anytime I felt off, I would call, within reasonable hours, of course, but I would call Dr. Mbogo. He would answer all my crazy questions, listen to all my rantings and everything. Really. And he gave me every information that I wanted, possible outcomes, negative and positive. He just answered all my questions. So he said, we are not going to do a double mastectomy. Nobody does chops limbs anymore. And he told me that the growth was small and, it would be manageable. So what my take home is that a patient must be comfortable with their oncologist. It helps a lot. So then so for me, in the spaces that I'm in, anytime anyone is frustrated, I'm just like, please talk to Dr. Mbogo because I don't know what else to tell you. He will answer all your questions. And then nobody has come back to tell me, oh, Dr. Mbogo was not helpful. That gentleman, may God give him many more years. Anyway, so we do 8 cycles of chemo. Then we do the operation to remove the lump and they remove lymph nodes as well. They find two lymph nodes have already started to get the cancerous growth, so it was good. They removed them. Now, I need to add here that NHIF helped pay a lot of the bills, helped pay the chemo, helped pay the operation, helped pay the radio. What they don't do is the other tests, the pre-tests, the ongoing tests. Those they do the ultrasound. No, they don't do the ultrasound. They do the X-ray. They'll do the MRI. They'll do those, but the tests to determine your liver functions and all of those they don't pay for. But still, it really comes in handy. Everyone needs to get on in NHIF. If you're not on NHIF and you don't have employment insurance, please let us terminate this webinar and get on. Although now we are enrolling for SHIF, and they say it will be better, but we'll see. We'll see if it will be better than NHIF. We still don't know what they are offering, in terms of treatment. It's sort of still, there's many gray areas, but we'll see. We hope it will be better. So my strain of cancer is HER2 positive, which means the hormone levels were and still are very high. And if not managed, the cancer can and will recur. Just to point out, Shannon Doherty, the American actress who died about 2 months ago, she had the same strain. And she stopped taking medicine because she thought to herself, well, I'm not sick. I look fine. I'm fine. I need to work. So she stopped taking her medicine and the cancer came back. And when it comes back, it is very aggressive. So her last kind of YouTube that she posted, she said she wished she had listened to the doctor and continued to take her medicine. So now I am on anastrozole to manage the hormone levels until 2026. Now, the downside, we shall not sugarcoat these things. The downside is that the medicine is so strong, it harms the skeletal frame, including your teeth. And it can stop your heart beating at any moment. This was what Dr. Mbogo told me. But the upside is it keeps the cancer away. So basically, it's a win-win. You're damned if you do, and you're damned if you don't. Now, what I have carried away from chemo is that I have neuropathy, which is the loss of feeling on my toes. So I cannot drive for long. So I'm bound to matatus and Ubers, which Ubers are not cheap, but matatus also have their inconveniences because I'm 5'11". Getting a matatu that accommodates the legs is sometimes a bit of a challenge. Otherwise, I'm relatively fine. I have lymphedema on my left hand, which is prone to swelling if I carry heavy things or if I overwork it. But, we are managing. The hairs, because chemo, the first medicine they give you, it harvests your hair follicles and all your hair falls off. So they do eventually grow back. The black skin does eventually go away and your body gets back to normalcy. You put on weight, you begin to look healthy. But I really do miss my long hair because the hair refuses to grow back. But anyway, God is good, we're alive. So the next section is follow-up. Now, I've had to do checkups every 6 months. I'm late even on this one since I completed treatment. So every 6 months you have to do, so just for them to make sure that the cancer hasn't, what they call metastasized, which it hasn't spread to various parts of the body. Now, I am also required to do get a bone density injection because of, again, the anastrozole every 6 months. And then I in the tests, I do X-ray, ultrasound, mammogram once a year. I see fellow patients getting PET scans, but in consultation with Dr. Mbogo, he has never told me to do a PET scan. I asked him, he said it wasn't necessary. So, because I think it has a lot of radiation, the process. So he felt I didn't need to do it, but if the doctor feels you need to do it, please just do it. So what I would advise here is that, say, as you're seeing all these doctors, as you're going through all these processes, save your results on email or get them emailed to you, because one, you will suffer from what is called chemo brain. You will forget everything, up to and including leaving food on the stove and forgetting to turn it off. So if you leave your results as you're going to see the doctor, they will make you do the tests again. It will not be a concern for them. They will make you repeat the tests, and those tests are not cheap. The cheapest one, when I did, was 15,000, minus the x-rays, of course. So the other tests were 15. And the internal liver organ ones, those ones, that one was about 5,000. But still, imagine if you have to repeat. You do a test and you have to repeat it. Another 5,000. It's quite imbalancing because the process of this treatment is absolutely expensive. So please get the results mailed to you. In the event that you have to go to the hospital, you can always access your email and then the results. So that section is over. We go to challenges. The first one is financial resources. It's expensive. The initial treatment is expensive. Continuous treatment is expensive. You have to do tests, scans, doctor visits, medicines, basically forever. If you have, depending on the type of cancer you have, but basically it's just a forever kind of thing that you have to do. And you cannot keep going back to your family for fundraising. It's really a challenge. So the next challenge is the overall effect that the treatment has on one's body. It never quite goes away. Your body never quite gets back to what it was before you got sick. The third challenge is the lack of information on where to go, access to treatment, what to expect, what to do, what not to do. The next one is, for me personally, I was on hormonal contraceptives for a very long time. There was no test done to determine my hormonal levels before, during, and after the use of these contraceptives. And I asked myself, were these a contributor to the rise in the levels of hormones in my body that mutated to cancer once I got stressed? I mean, that's something that I ask myself often. Then another thing is a lack of awareness in society. Even the educated people make the most asinine comments. I mean, the things I have heard, it just shocks you because you think, okay, this person has been to school. What are they talking about? Then another issue is dietary demands. Your diet definitely has to change. You need to eat healthier. And of course, this comes as a price. Kuku kienyeji is definitely more expensive than the hormone-fed chicken. That's one. Fish, homegrown fish from Lake Victoria is definitely more expensive than the fish that is pond-grown, which is fed with hormones. So those are the things, you have to now prepare yourself for a little bit. Fruits, whereas if you're not a fruity person, you have to factor in fruits in your diet. And then we are told to stay away from food with preservatives, but yet these are the nicest sausages. I can't eat sausages, I can't eat bacon, I can't, anyway, God is good. So then there is another one, which for me was a concern, and I think it's a concern, but we are afraid to say it. Well-meaning family coming to visit when they are sick with communicable diseases. They are sweet to want to come and visit you, but they will leave you with those diseases. And because your immune system is compromised, what happens? You get more ill than you ordinarily should be. Then there's the most important one. Everyone suddenly becomes a doctor. The minute you say you have cancer, everyone becomes an oncologist. To those that really want to help and take on this, don't, please, just try and hold yourself and not make an ill-informed medical comment to someone who has just told you that they have cancer, please. And then to those that are told, oh, do this, try that, what, do. Just tell them, like I do, I say, I must consult my oncologist to ask him if it will be okay with the treatment he's giving me. Instead of making enemies, you're already sick. You don't need more stress than you have. So you just tell them, I need to consult the oncologist. But still, if you can avoid offering advice, just try and avoid it. I know it burns, but try and avoid it. Another issue is stigmatization. Some people say that AIDS is a better disease, but the jury is out there. Is it? AIDS better than cancer? I don't know. But what I know is that if cancer is detected early, you can live a very full and productive life post-treatment. Another issue that we need to talk about, and which I guess is why we're here, is getting the government more involved in cancer issues, in creating more awareness. especially in the middle class. I feel there's not enough info out there that can help people who don't know, basically. Let me put it that way. So one thing I would say is, another issue is the negative Nancy's and Debbie Downers. That's what I call them. You need to be aware that not everyone will support you as a cancer patient. There are those who will declare you dead. There are those who will wish you death. And there are those who think that the disease is contagious and will run away. Even the one who vows in sickness and in health will run like Kipchoge Keino. If you don't know who Kipchoge Keino is, please Google. He is legendary. So they will run like Kipchoge Keino. But don't take it personally. It's not about you, it's about them. What you do is you focus on your health, keep your sanity, and you stay away from those people as much as you can. I experienced those as well. So this I know, I'm talking from a point of first-hand experience. So you're sick, yes, you've gone through the treatment, yes, you're now post-recovery, your cancer, oh God, the English has gone again. You're in remission, yes, thank you, you're in remission. This is the time to leave your house in order. Sort out your estate, write a will. The trustee, national government trustee, is now offering will writing for 500 shillings for free, and 500 shillings a year to keep the will in their offices. Please, you're not dying. I mean, I don't know why we believe that writing a will means we are dying. No, you're not dying, but just leave your situation tidy so that your family, who is already stressed enough, God forbid should you go because you have cancer, but so that the grief is lessened by the fact that you have sorted out your issues. It's not shameful. It's not a bad thing to do. It's just something that needs to do it. You lose nothing from doing it, but you leave your family secure and sorted out. Okay. Another section is breakdown in communication concerns and how I raised them. So I suspect that even Dr. Mbogo suspect that I got COVID in the middle of my chemo treatment, because I attended a family function. One of my cousins had it, and she didn't say that she had it, but anyway. So when I went back for my next chemo session, I told the doctor that I was feeling bad, and he told me to take Panadol. But if I hadn't been, assertive and had an assertive personality, I really would not be telling this story, because I would have gone. But I insisted and I insisted, and it was found out that I had an infection in my chest. Yeah, that doctor didn't attend to me again. I said, please let him not show up near me, because, and apparently they say cancer patients become hypochondriac. We suffer from hypochondriasis. But take your time to find out what is going on. Even if I'm suffering from hypochondriasis, reassure me that, all will be well, but don't just dismiss the patient just because you assume that they, like others, are suffering from hypochondriasis. So Dr. Mbogo saved me from misdiagnosis, from all these experiences that other people have. Gosh, it's for me, James Mbogo saved me from any and every anxiety that I could possibly have had through this journey. That's all I can say. I have not had those challenges, those experiences. I honestly haven't. So the last section is what patients can do to reduce misdiagnosis and delays. I would advise to ask questions and then get second opinions. The second opinions are expensive, but in the end, they may save your life. Talk to people who have gone through the journey before you. Join groups of fellow patients. They offer very insightful advice. Education and awareness of the fact that cancer is not a death sentence that needs to happen. A lot of people run away from treatment because everyone starts crying once they're informed that you're unwell. I mean, naturally, but we need to be educated that it is not, we are not dying just because it has been said that we have cancer. No. So because patients believe that they are dying, some stop treatment. they stop conventional treatment and they go for herbs, or whatever other alternative forms of treatment. I can say conservatively that I have not seen anyone recover from alternative forms of treatment. There are people who say they've seen, I haven't myself. So I cannot offer that as a conclusive, constructive opinion. I have seen people recover from conventional medicine. I haven't seen anyone recover from any alternative treatment. Oh, and to summarize it, not every doctor enjoys their job. No ill will towards doctors, but my journey taught me that not every doctor enjoys their job. It's a sad reality. So when you're choosing your doctor, choose your doctor well. Thank you.
All right. Wow. Thank you so much, Mary, for just sharing your story with us. We're very humble that you would come and give us that patient perspective that we often overlook. And thank you for the learning points as well. You know, we can see in relation to our topic, there's some issues which you encountered when you were first seeking a diagnosis. Lack of information, you've highlighted access to care, and you've also taught us a lot about you mentioned the boundaries of patient and family involvement in care. We really appreciate that. So thank you so much, Mary, for that. We'll move on to the next part of our discussion today. We'll be having Dr. Okutoi, who is the Director of Healthcare Quality in Kenyatta National Hospital. And she's also the President of the Society of Quality Healthcare in Kenya. And she will be explaining to us more about diagnostic safety. You know, where does it start and how can we improve it, and how can we improve the experience of patients like Mary in terms of getting a diagnosis and facilitating treatment. So thank you so much, Mary. We'll move on to the next part of the discussion now. Welcome, Dr. Okutoi.
Good afternoon.
Good afternoon.
Are my slides showing?
Yes, I can see your slides and we can hear you loud and clear.
Great. Allow me just to appreciate Mary for being courageous once again, because I know she's done this many times, but just sharing your story and us knowing how it has been, and even how, as the healthcare system, we can reflect and show up better for the next patient who's walking on that journey. And you've also shed light on a lot of the support you had, the peer groups, and this one doctor who's worked with you. Thank you very much. Allow me, as I share some highlights on diagnostic safety, to just also use the story that you have shared on some decision points. For example, you say that you had chest pain, and so it was assumed. So I think there's a lot that we benefit from. And then also, you've brought in your heart to you as a person. You experience it. This is the challenges you had before even being able to show up for the test. It was real. There were financial issues, but at the same time, you also had to put yourself together to go for it. So thank you very much for sharing this story with us. When we talk of defining what diagnostic safety is, we are actually talking about having safe diagnosis that, or diagnosis that has no harm, and it goes to even having no error. And the main objective is we'd want an accurate diagnosis that is also timely, and that is sufficient enough to help us address the patient's problem. And it has to be person-centered. The patient also has to be part of it to see that there is value in I going through this pain for the purpose of getting this sample, or for the purpose of getting this sufficient node that can be tested. So it has to have the objective that it will help us address the patient's problem, and it should also be equitable, that there should be access to what is happening, that nobody is to what is required, and nobody is disenfranchised or not enabled to access because of gender or tribe or anything that differentiates. So that is the objective of it. But we also talk about when harm happens and what is this diagnostic error. So when you're talking about diagnostic error, is anything that would predispose the patient to harm or may lead to harm, but they're in two groups. Any delay, wrong or misdiagnosis. When we have sufficient tests or results, or we have a sufficient story or data that is available, yet this does not lead at that time, because diagnosis is based on time. And at that time, we are not able to give the diagnosis that will lead to resolving the problem. Then we say it is a diagnostic error. And if we have an accurate diagnosis, but that accurate diagnosis has not been explained to the patient to the extent that it will help that patient get the next help and the family, then also that is diagnostic error. So it has two parts: the aspect of delay, it being wrong or missed, but then also communication to the patient. So that is the last end, that the patient needs to know what they are having for it to be considered not an error. What is the pattern of a diagnostic error? How often does this happen? In a systematic review, it is thought that diagnostic error happens in about 16% globally as a cause of harm that is preventable. And in a primary care setting, it is even much more common. So there are more delay, wrong, missed, or lack of communication to do with diagnosis at the lower levels than at the higher levels of care systems. And that is how it is meant that you go to the next level of consultation and to the next. So it means that when you talk about harm, when we report whatever is happening in the hospital, it is a tip of the iceberg. When we do community studies, when you go to the primary levels, they are much more commoner, and it is the commonest cause of delay of care in the primary care settings. In the OECD countries, studies have shown that 5% of expenditure for chronic disease goes towards diagnostic errors. In Africa, a few studies have been done to quantify, but just to quote one, that in our medical error reporting system at KNH, the diagnostic errors form the second commonest medical errors. And by the way, most of the diagnostic errors will not cause harm. Most of them don't cause harm, but a few cause harm. And those that cause harm are very much of our concern. And so it is important that we identify this number. When you say second commonest of medical errors happening, it may not be the second commonest in causing harm, but it's important because that is a tip of the iceberg. We need to identify the circumstances that leads to this. Just to look at the diagnostic process, Mary has told us that she felt alarmed, she felt some growth, the hand started getting heavy. So it starts with the patient. The patient experiences a symptom, and the patient has this sign or this growth or this that is different, or a fever. So they experience a symptom that makes them to go to seek care in the health system. And so when they come to the health system, they provide information to the clinician. The clinician examines, they do the tests. At times they refer to another higher level space for the purpose of getting more consultation. So there is the synthesis of all this information that happens within the system. And so the ball can drop within this information gathering when the result is coming from one lab to the file. Lucky if there is a health information system that is an LMIS that can just offload the patient's site to the patient's electronic health record. So there is synthesis of information and interaction. And it is a cycle because one test can lead you to determining you need another. Mary talked of something called the FISH test, HER2 positive. Those were not the initial tests. The initial tests were different. The initial markings of even staging. Diseases like cancer, there is the initial diagnosis, and then there is the immunomarkers. Then there is also the staging to find out where are we as far as the organs. So this forms a complex interaction that at times the ball may fall, even at the level of just examination or at the level of the test in the lab. And so that process, when done rightly, should lead to a final diagnosis. And so then the diagnosis is shared, communicated to the patient, and a treatment plan is made. And it is possible that we do not get a final diagnosis, but you have many differentials. But the doctor will determine with these many differentials, which one may kill or which one should I go with. And so also there is the decision of just making out, this is the most likely, this is the most unlikely, and at times time by itself could tell. Depending on the kind of disease, you may have good time to decide and to investigate more, and at times you need to make a very quick decision. And as Mary has mentioned, there is money factor in it. There is whether you're mentally ready to have it. So it means it is complex. We should optimize that process to be able to start the treatment that the patient requires. And so when you look at the causes of diagnostic errors within healthcare, they are classified into three: the ones related to the system, then the ones related to the cognitive aspects of the clinician. The doctor is one of the most, not the most, but one key important part in making the diagnosis. But they do not stand alone. They are supported by the team. When the nurse does the triage, when the lab takes the various tests and they look at the various parameters, they help the doctor go to the next level of the cognitive aspect. And so when I'm talking about the doctor, I'm talking about the clinical officer who is sitting maybe in a lower level facility, or a clinical officer who's specialized. I'm talking about that nurse who in that dispensary is the one who is making the diagnosis. They will be affected by, they will be required to make a decision, and that is the cognitive aspect. So allow me to use the term the doctor, but just know that even in nursing, there is a care plan that is usually made, and they make a nursing diagnosis. So we're talking about that person who will see this patient. It just happens that now for the case of Mary, when you're talking about cancer, so we're talking about now the specialist to make that decision, being supported by all of us in the system. Then there is communication. So there are system, cognitive, and communication aspects that can lead to the error. When you look across the journey, there is history taking, physical exam. It is thought that that quite happens well. But when it comes to the synthesis, to having an hypothesis and looking at the tests and going back, remember the previous chart had a cycle. So that is the right way, that you get the tests, you determine to examine again, you repeat. That's why every other visit a patient is seen, they can be examined. They can be asked for more tests, maybe for monitoring, but maybe just we have not made a diagnosis yet, and even during follow-up. So the diagnostic process has potential for harm across, but where error happens most, it is the point of synthesis of the information that this is what I've examined and this is what I'm seeing, and the tests coming back. It is thought that in some outpatient clinics, 41% of the tests do not return back to the patient. Studies have shown in different levels, different institutions, there are times to get a batch of tests that remain. For those who go for screening, we do screening and the tests do not get back to help the patients. So those are also errors that could be considered as system errors. So these cognitive errors, what are they? cognitive errors is where we fault by thinking times fast or like experts. Let me put it as what we call the system one way of thinking. We make a lot of mental shortcuts, and those mental shortcuts make us to not make the right diagnosis. But basically, when you talk about these cognitive errors, it is to do with assessment and then also not considering other things. Is it possible that it is something else? So these mental shortcuts, which are called heuristic way of thinking, they are commoner among the very proficient, people who've been there for long. They have a lot of experience, but their shortcuts are a bit hardwired. Those who are new in the system, they go back to rational way of thinking. So that's where you may find diagnostic errors happening even in places where we have very experienced, specialized people, because at times we make a lot of mental shortcuts. And of course, for you to get experience is a lot of time. And then also it's a lot of also learning from your mistakes. But now science has taught us that it is possible to get towards the more rational way of thinking. And so the difficulties, let me just choose one, like premature closure or having some form of attribution. Mary alluded to that. Like, for example, she came with chest pain and we just say, cancer patient, you've gone through radio, so it is this way. We do not think, could this be an infection? Could this be something else? We see somebody who is not lean, who is small-bodied and having left-sided chest pain, and we decide this could not be an MI because they are too young and they have a good BMI. So there are various mental models that could make us error, and so it is good that the clinical team get to know about it. The one called availability is whereby we think, because this has happened yesterday, it is likely that it will happen again. When I was a resident, we had a colleague who on one night, I think, had almost 2 or 3 patients who were what we call negative laparotomy. It was because of an ectopic. We thought the patient had an ectopic, but 3 of them consistently did not have. Why? Because the previous exposure is an ectopic had been missed. And so everybody was so anxious. This cannot happen again. So at times you just keep seeing what you imagine you are seeing, yet that may not be it. So the idea here is the solution is we go to what is called system 2 kind of thinking of solving the problems by being more proactive, considering the opposite, being more rational, saying what could this be? What are the differentials? This is a picture of a pilot who is thought that before the crash, they were wondering what's a mountain goat doing up here in the cloud. They did not realize the lack of situation awareness that they had actually lost height. they were now crashing to the mountains. You see, they are laughing, just wondering, oh, what is a mountain goat doing up here in the sky? They were actually just going to crash. Here is ABC. So when you see it in the context, you know that that is B, it is not 13. But when you see it alone, you may think it is 13. So it is important in healthcare provision for us to be aware. What is that situational awareness? What is that context? There are things that we've all learned about age. What is the temperature? What is the blood pressure? So what could this be telling me? So what diagnosis can I rescue? Is it a problem that there is an imminent sign, or is it an issue that we've not made the right diagnosis? So the context is very important, and this comes most of the time with experience or with access to the experience, so that in case you see something, and then how else does this come with a team effort, teamwork? For those who are surgeons, when do you suspect that let's say you're a gynecologist, you've gone to the peritoneum, you have punctured something? When do you suspect it is different? So do you say this, what I'm seeing can't be a mountain goat in the mountain, in the clouds? It can't be a mountain goat in the clouds because they cannot be found here. I'm seeing blood. I should not be seeing blood here. Or why have you continued coughing blood after this kind of treatment, maybe we do not have the diagnosis. Why is this pain continuing? So just coming back to the system two, thinking that, is it possible that we are not yet there? Being open for that differential diagnosis. The system factors are usually a little bit easier to address than the cognitive factors that I've talked about, the ones that are related to the people and those doing tests. So the system factors are multiple, but allow me to point out the human factor, where it combines the cognitive factors and the enabling environment, the teamwork. So as institutions, we should address especially the human factor so that we create enabling environment for safer diagnosis, be it in having multidisciplinary teams that can discuss in how the tests are done and the controls that enable us to raise a flag, how much do we separate the noise from the real issues, that we may reduce the noise for the purpose of especially high risk situations, we are able to make the right diagnosis and salvage the patient. So the others include up to policies and equipment, but we'll go to the system factors when we talk of intervention. Then aspects of communication is very important. A communication error for diagnosis, because remember, the patient may be in the ward admitted, but we are still in the diagnostic process. So that handing over, how did the patient sleep? That major ward round, this is where we are today, can enable correct information to help us reroute to the right diagnosis or to the current, to update and review. That's why it is called a review, the diagnosis that we had. At this time, this is how we were performing, but now we are changing, or we are updating our diagnosis to, because we have observed ABCD, we have reacted like this to care, we think this is where we are, we need these more tests. So the handing over, the documentations, and just communication across the system, whether it is for the test results to arrive and for them to be acted upon. And then also inadequate time. Whenever there are busy clinics, we may have inadequate time to make the diagnosis. So we need to be aware of what are these red flags. And each department, each system has its own challenges or things that you say you will not fail to see this. For example, I'm a gynecologist, and when it comes to the ectopic pregnancy, we say whenever there's amenorrhea and low abdominal pain, whenever there's missing of menses for somebody who is in reproductive age, and there is low abdominal pain, all the other diagnoses can be here or there, but the worst it could be is an ectopic, because they can bleed to death. And so you have to confirm, is it likely that this is an ectopic pregnancy, but just that they are not bleeding? These severe abdominal pains, when I do an ultrasound, I need to do a pregnancy test. So when you are in a hurry, it is possible that you don't have time to do this evaluation. So determine which of these diagnoses, when they come to an accident and emergency, when they come to the consultation, they are high risk for my team. So we need to have a way of saying that we go back to system 2, that we become more rational, more thorough, and say, what if? So there are these diagnoses that patients who move in the system for a while without getting a diagnosis, especially the rare conditions. There's one here, the one maker, it is called schwannomatosis. The average is 16.7 years to get, median years to get the diagnosis, because it is a genetic disease, it is non-specific and intermittent symptoms. This is just an example. In our setting, could involve even up to people suffering from sickle cell. It is possible that they could just be coming, this time they're saying malaria, another time anemia, without going back. So in each region and area, it is good for us to determine what are these diagnoses that are rare, and it's possible they could go through the system even for 2-3 years without getting the diagnosis. And if it's common in a certain area, then we include it. But the purely rare diseases, there is a code and an approach for them, so that we encourage prompt diagnosis, and especially for it to be clear, to document that we have done this, we have excluded the other, but we do not have a diagnosis. Then we work with the family. Is there any familial history? Whom are we referring to? So there are some illnesses that are very unspecified and it may take a while. But it is possible that some are classified here in our setting, which should not be. I've seen some patients with like multiple myeloma can be very nonspecific and take a while to get a diagnosis. But there are also others which it is possible for an expert to work on it. So going forward, what are we supposed to do? These are borrowed from the WHO World Patient Safety Day guidance, that for us to have a model that ensures we have diagnostic safety, we have to consider the health workers. We have to consider the systems where services are provided. We have to consider the technology and the diagnostic devices. And we have to consider the patients and their representation. But all this should be seen through the lens of policy. What can we do at policy level, at institution, at point of care, and what more information, what data, what research, because we know very little about diagnostic errors within our setting, and those are opportunities to learn. And so that enables us to have safer diagnosis and better outcomes. The patients should equally be engaged from the point of admission through their continuity of care in the hospital. You came with pain, you've started being treated for a certain diagnosis. So that bedside review by the team, that change of shift, it is a good time for us to know, are we doing well or are we not? Also, the discharge planning should happen through the stay of the patient, so they know when they go home, how will they take care of themselves? Or if they see this sign, is it likely that they should come back, that the disease is progressing to something else? So for some diseases, it's very important because we may send you home on treatment, but it may be presumptive, or the disease has potential to escalate or to become worse. And so it is good for the patients to know what are the danger signs. When should I run back home, run back to hospital, even if being discharged home? Then we encourage the families also to be part of our hospital processes. There's a standard to make families be hospital advisors. They're part of like the patient affairs team, sit at the board, because they represent something special. So depending on your small clinic or on whatever specialty you're working on, it is possible to have representation from patients. So communication is most important across and within the hospital, and it's expensive when that breaks down. And so we need to learn how to communicate beyond it being accurate. You heard what Mary said. There are times you just do not feel like. It is mostly about the communication. Maybe the patient is feeling not being heard. And if a patient is not feeling like they're being heard and they're getting this treatment that is very specialized or that is also difficult, it will be difficult for them to adhere. So it is important that patients are also welcomed to communicate in case they're being harmed. They can say this is what they are feeling, whether in the diagnostic process or in their treatment. And we require to be trained the competency on how to communicate. Just beyond the techniques, we need to do it and we need to get that feedback. I don't know whether Mary had, the doctor has ever gotten a feedback on why there is a feel of distance. And we are in this process learning. So it means we should also be able to model it. The older or the ones who've been in the system to model it, but the hospital to make enabling environments about this. And there are specific approaches for communication for different spaces, depending on the health literacy. But it is said that health literacy is conferred by the health system. When a patient comes with a baby, it is me, the gynecologist, or the pediatrician who will tell them the information about when they should come back to hospital. So I confer to them the information that they will use. And so specific communication approaches could be used for different spaces. allow me just to say this according to Mary's story, that indeed a patient has a big role. Patient should be a good historian to say the process started like this, and this is what happened next. They should take advantage of screening opportunities for diseases, because that is also where diagnosis can happen early. They should keep accurate records. She's mentioned before you start chemo, put them on email so that you can download them. That is a good approach. Have a folder, have some copies in the cloud or somewhere, and let the hospital also have mechanisms to keep your documents together. Then also speak up. If things are not tying, as a patient, ask, what else could this be? Know what is expected of you and when to come for follow-up, and give feedback in case there's a diagnostic error. Give feedback to the system so that the system can learn and become an advocate, like Mary has become an advocate for patient safety, for cancer patients. And she says she has also she was helped by others. So she's also giving back. What is the role of a doctor? I think the role of a doctor, because we are experts, and at expert level, we can err at the intuitive or that mental shortcut. So let us get towards mixing the expertness and the thinking deliberately and rationally, so that we make fewer errors, because there are errors that are related expert level. So we need to know that there could be something else. There's that study by Singh that said in ambulatory setting where the diagnosis was wrong, almost 81%, there were no differentials. So always put some differential diagnosis. Differential diagnosis is, what else could this be? So when you put those differential, sometime tomorrow when the next person will be coming, they'll also think about it, because there's an error of us holding on to the diagnosis that the previous person said, just because it was put that way. So always put some differential. As much as you think this is your final diagnosis, put a differential. What else could this be? So for the doctors, we should avoid being overconfident. And whenever there are system issues that lead to wrong diagnosis, we should be advocates, because we can be able to see it, that let us not organize care like this. Our results are showing this and the picture is different. Could there be something? So let us be advocates to address system issues, and we should be open-minded and put the differentials there. And as the patient's condition evolves, we should keep matching the symptoms and the diagnosis and going back to more tests. You remember it was a wheel. So you can go back, like these symptoms are evolving this way, so it is possible to be different. And then let the patients be our partners, and we should elicit all help. It is said, taking a phone call and calling your colleague, what could this be? May I hear you? Or could you come and review? What Mary said, a second opinion. And in structured institutions, especially with regard to cancer and other complex diseases, there is multidisciplinary teams. Let us utilize the multidisciplinary teams for the purpose of safer diagnosis. It will make it timely and accurate and even efficient in terms of money when we're able to put our minds together. And for us, the healthcare system, to make that accessible, let it be accessible to the patient. And so as I come to a close, allow me just to appreciate that as we celebrate the World Patient Safety Day for 2024, indeed, diagnostic safety and addressing or reducing the error that happen in diagnosis is complex, because it comes from the clinical, going to the diagnostics, to the labs, even to how our devices are regulated, how we import the testing equipment, their sensitivity, specificity. It comes to the complex. At times the patient comes already with Mr. Google. It is said that Google has a very low specificity. It may have a sensitivity of 54%, but the specificity would go up to 0. So we come in this complex situation. And so we need to utilize the team. We need to put the patient at the center and listen. And as we interact with the test, as we coordinate all this, let the systems be organized in a manner that the results come in a timely way and decisions are made and we're able to communicate. Let whatever we decide, or if we are lost, we don't know what is happening, let the patient know, because they will be our help. And so this is the slogan of get it right, make it safe is very important. It will help us to remember that we need to get it right. And when we are doubting, it is good for us to go to the next level. And there are all these interventions we've mentioned, but just to summarize that we need to be system thinkers, enable and create an enabling environment whereby it is easy to do the right thing, making human factors approach in how we design our systems. And whenever there is an error, we use the human factor approach to investigate that error. Why did it happen and how could we make it happen less? And also actively engaging our families and the patients, having the health workforce be empowered, both for skills, knowledge, practice, using simulation, them having opportunities to access help, even up to decision support helps. Some are online, and having this accessible to our health workforce for accurate diagnosis, and then being supported by their seniors, even how we organize in the system. And this has to be bought by the healthcare leaders for this to happen, so that there are policies that enable the correctness across board. Allow me to end at that and to truly appreciate that, Mary, you gave us the platform for the lens to look at especially diagnostic safety. Thank you very much.
Thank you so much, Dr. Butoi. That was a very, very informative presentation. And I think we have all been edified by it. It's interesting to learn how it's not just about getting the correct diagnosis. There's a time component to it as well. And it's also interesting to see all the factors that come into play when it comes to making a diagnosis. We do have a few questions, so we'll go into the Q&A session right now. If you have any question, kindly post it in the chat box and we will get to it. So there's an anonymous attendee who has said that it seems like a lot of training needs to be done for people involved in primary care settings. And I think it's well known that primary care and emergency settings are usually high-risk areas for diagnostic errors because we have such high patient volumes, and sometimes you're making a diagnosis amid certain uncertainty. So, Dr. Butoi, what other factors do you think, is it just the training, or what else do you think needs to be brought into play, especially in primary care settings? Or what would you say to that healthcare practitioner who is in a primary care settings and constantly overwhelmed by patient volumes? What would be your advice? What would be your advice to them?
Yeah, I think the primary care settings are, have their risks, because first of all, we most of the time have the new or just newly qualified. So also there's the level of experience there. But that notwithstanding, it is said that the part of knowledge by itself is not usually the big challenge. The bigger problem is the synthesis of the knowledge. So it means that the issue of having more rational thinking in how we are making diagnosis would help. And also just not being overconfident and reflecting, learning on when things go wrong, or if there are opportunities. If there are opportunities for you to learn from what I did wrong, then you know you'll not have to repeat it. So those are part of, for example, during the ward rounds, they are discussed, or during the grand rounds. In the primary care setting, who is there to have that conversation? So as a system, I think we need to have opportunities for mentorship for those at the lower levels. Let them have an opportunity for discussing and learning from harm that happens. And then also just internal factors, fatigue, sleep, Yeah, if I'm doing this number of shifts, if I'm moonlighting, what are these risks that are associated with it? And just knowing what level of risk averseness and risk acceptance we can take. And if in a primary care setting, there could be some common diagnosis. So it is said that whereas cancer patients could take long in the system and have delay in the diagnosis, it is possible that we are having just more errors to do with common things, with flus, with just the common diagnosis that happened. So it means we need to reflect on our diagnosis, even if they are not those life-threatening. And then also we have to look at the diagnostic support that we have. Do we have access to that support and to the seniors? And the external factors, we've talked of workload, distraction. So when you investigate an incident as a team leader, look at the workload. Was there anything that could have distracted this team? And was there any possibility of support by a peer? There are people who are afraid of calling their peers, or they're afraid of calling their supervisor. So the hospitals need to create mechanisms for support horizontally and support going up, and even referral. When I call, because maybe the primary care setting, the next level is now to Mbagathi or to Kenyatta. So we need to have mechanisms to enable help for these practitioners in the primary care setting, and have the patients also just have a voice. I think Mary being here is a testament that also the patients can also be the ones who are asking, what if, especially for those rare diseases. I've seen patients who are experts in their disease because it is not common and they have read so much about it. So is it possible also to elevate the patient's voice? A mother who's had other children and is saying, "Hi, huyu mtoto ni tofauti. The other one was not like this. There is something." So let the patient be heard and also be the ones to raise an alarm that it is, what if it is something else? This is more serious than just I going back home with this child. Could we find out more? Yeah. Thank you.
All right. Thank you, Dr. Kutoi. It's interesting that you've mentioned the patient's voice. So that leads us to our next question, which I would like Mary to take. So we have Martin Nafuko online, and he says he almost had his fingers amputated by an over-enthusiastic general surgeon, but he was able to voice his concerns and advise, and he managed to get a treatment plan that did not involve amputation. Mary, I think you alluded to something similar in your story about how they had recommended a double mastectomy for you, and you managed to use your voice in trying to take charge of your treatment and trying to be involved in your treatment. So Mary, what would you say to other patients in our system who maybe do not have the experience or the patient education that they need to speak up? What would be best for them, or how can they navigate such situations to reduce errors in their diagnosis and also to reduce delays in their care system?
Hey, thanks, Michelle. Now, I read that with absolute mortification. He, like me, obeyed their gut, obeyed their instinct, and his instinct said, no, that's not it. Now, I would encourage patients to, one, research. Once you're given a diagnosis, research about it, so that going forward, you know, these are the options that I have. This may work, this may not work, but not everybody has the privilege, one of the kind of background that I have. So again, it boils down to educating the masses. We need to have a nationwide campaign. We need to have a nationwide awareness on how, because the doctor goes to school for their course. However, the doctor may be wrong. So if your body is telling you there's something going on, because like for me, it was just instinct, discernment. I listened to this doctor talk about how he needed to do a double mastectomy, and I was like, no, I hadn't even done my research yet. But I looked at him and I was like, no, this is money making. So I obeyed my gut and I went down. I sat in my house and I said, no, this is not for me. So what would I advise? Listen to your gut. Sit in front of the doctor. Listen to yourself. When the doctor is telling you this is what is wrong with you, that is what is wrong with you. Listen to yourself and ask, is this it? Talk to other people, because these days with social media, there's so many platforms where you can get like people who are going through the same thing as you. Talk to them, tell them, I'm feeling this. They probably have also felt the same this. They will tell you, okay, go and see Dr. So-and-so, go for a second opinion, go and do whatever, so that you confirm that this is actually what it is. And I'm very happy with Nafuko for listening to his inner voice and not losing his fingers. But it's a tall order to get people to actually have the guts to challenge a medical opinion. It will take a lot. It will take a lot of work to do.
All right, thank you, Mary. Thank you for that. So we'll move on to the next question. We'll combine two of the questions, and this is to you, Dr. Okutoi. An anonymous attendee is asking, as a quality officer, what clinical audits can be done to identify these diagnostic errors? Because it's interesting to note that we discussed in the presentation that not all of them cause harm. And in situations where there's no resultant harm, you find that as healthcare workers, we are not very quick to bring them up as points for improvement. So how can we audit this and identify the errors? And then as a follow-up to that, what if we audit and we find that there are clinicians who are consistently misdiagnosing patients? There's Daisy Ogoya is asking, are there any measures that are taken in order to deal with such?
Thank you very much. I think those are loaded questions, but at least we know that errors happen and very few cause harm. But that harm at times is the magnitude and the cost and everything. We've been told of 5% of health expenditure. That's so much. It could be used for something else. And we don't know what that could mean. It could mean a life. It could mean disease being spread more. And so it's very important for us to address this. It is significant. So by looking at the errors and not necessarily just those that cause harm will help us. So what are errors that are happening? The delays are error. The wrong diagnosis that we finally get right that does not cause a patient to be harmed is also a big error. So I think if we are able in each of the department, we've talked of the diagnostic journey, there's information, there is the test, there is the physical exam. So it requires the senior to take leadership, that this place we will learn. And so did we fail at physical examination, at history taking? Didn't we listen that the patient mentioned this, or it's only written in the cardex by the nurse? We forgot about it. The clinical team forgot about that important thing that will help us. So the whole idea is, how do we go back to system 2, to thinking in a rational way? And when the patient's things are not tying, to accept that something is not tying and not to prematurely close. And so that's why diagnostic errors are complex, because it has a lot of the cognitive part, but at the same time, we are aware that the system issues come in, how the results, how quick they come. We are told some standards, the JCI standard, I think, has a relaying of critical results. When you get critical results of this potassium, or we get these cells that look cancerous, though we are not sure, how quick do we go back to have that information to the clinician so that they make the next decision in terms of care, so that we do not delay treating the problem that brought the patient? So there are multiple approaches that we can do. And so you can see, with regards to audit, it means the laboratory could do their own audit, even the diagnostics. And then also, at times we end up finding this diagnosis in the at postmortem. So also that's another opportunity for us to know whether we did the right treatment or not. So whenever we truly think we did not get it, it is good to do a postmortem, but there are some that are routinely done, like for maternal deaths, routinely they do a postmortem. So those are opportunities to learn, because it is one thing to error and another thing not to learn from your error. And some of the errors are to do with how you've organized yourself. And so that's why leadership is important, to reflect on their outcomes. What is delaying the results from arriving, and why were the results wrong? Are we having the second and third sign off? So the pathologists and the lab benches, they know how to increase the accuracy. What is the level of a resident and a consultant? How do they relate for the purpose of reducing diagnostic errors? And so I think it is a wider system. It is actually complex. Yeah, diagnostic safety is complex, and it takes leadership to face it and to cascade that. So we expect like the various teams, even up to including nursing. I was in a ward round at some point many years ago, and there was a patient who came having bled, and we thought that she had menorrhagia. And one of the nurses just said, when I passed there, when I looked at that heart, it did not seem like it was just blood. It smelled like now with, in fact, she had been being followed up for infertility. So nobody would have imagined it was to do with a pregnancy. And it is true, she was bleeding, but having lost a pregnancy which she wasn't aware. So that nurse mentioning, so the aspect of team is very important, how the team functions, even if it is the lowermost person who has identified something. We had missed to do a pregnancy test, assuming that she has been infertile for very long. But what was leading her to bleed and almost bleeding to death was a pregnancy. So even the unlikely. So always ask what if, what are the differential? Sorry, the question cannot be fully answered, but they are policy level interventions. There are those at the level of facility, and there are those at the level of the point of care. So there are multiple approaches, but monitoring each department, I think, can choose to work with something, and the hospital also can assess, like from patient safety, we look at the errors that are reported, because they report both near misses and harmful events. So we are able to see where we are as a hospital. So it is a tip of the iceberg. Thank you.
All right. Thank you for that, Dr. Kutui. I can see that you've emphasized a learning health system. And I remember that you had asked a question earlier on whether Mary was able to go back and just give feedback to the doctor who she had a communication breakdown with. We have an anonymous attendee saying that communication errors have come across as central to reducing. Communication has come across as central to reducing errors. So Mary, did you feel like there was an opportunity to give feedback to those providers whom you didn't have the best interaction with? Is that something that you felt could be improved in the patient and provider interaction?
I'm back. Now, when I went in the 21 days between the chemo sessions, I managed to get Dr. Mbogo to figure out what was going on. So when I went back for the next chemo session, I went with the x-rays that I had been sent to do. And I asked the nurse, sweetie, did we not have a discussion about the pain I felt? It wasn't not my chest, it was my back, where the ribs are supposed to be. So she said, yes. And you told me to tell Dr. So-and-so. She said, yes. And I told her, well, this is the result of Dr. So-and-so's telling me to take Panadol. And there was an instant panic. So they called Dr. Mbogo, who came running. I missed that out. Who came running from wherever he was, because they told him, your patient is going crazy. And I said, please do not allow this particular doctor to step. The rooms are cubicled and there's a curtain. I said, please don't allow Dr. So-and-so to step beyond that curtain and to ever touch me. Because really, I do not need that ever in my space. Actually, when he was telling me to take Panadol, he was on his phone. And I just said, kindly, don't. If it's his duty, let him kindly skip me and see other patients. And that was my feedback. And I never saw him handle me again. I was just like, please. Mentally, I'm not in a space to handle anything like that. And they handled it very well. He never saw me again until I finished my chemo and until I finished my radio, because after radio, then you're also supposed to go back periodically and see the doctor. I saw the others, but not this particular one. And later on, when I went back for my review, I heard that he had actually left. He wasn't working there anymore. So I don't know if it was as a result of me and other patients complaining, or if it was something that happened elsewhere. I couldn't have been bothered to figure that out.
All right, thank you, Mary. It's unfortunate that that was your interaction and that you didn't have a chance to give us feedback. But thank you for highlighting some of the things that we do during consultations that can really put the patient off. And we take that as positive feedback, and we shall try to keep learning from that. Unfortunately, we're running short of time, so we will not be able to address all the questions, but I will direct one more question to Dr. Okutoi. There's an anonymous attendee asking, who has stated that there was recently a case of a doctor being sued for a diagnosis of TB where the tests were clean, but the doctor treated based on high index of suspicion. So even in arriving at this diagnosis, when you take into account index of suspicion and the cognitive models that we tend to revert to, where do we draw the line in deciding that this is a diagnostic error that has caused harm vis-a-vis deciding that this was actually the best thing to do for this patient in this case? What would you say to that question?
Yeah, I know the patients who've had a treatment for TB presumptively. However, I think such decisions are better made by system 2 kind of thinking, which is having the rational. You have a comprehensive evaluation and you rationalize that and have that presented. If it is in KNH, you will be a team. You will not be alone. And before, I'm sorry for the aspects of being defensive, but before the court or even going to an inquiry at the board, peer decisions are usually taken seriously. So whenever it comes to that, it is possible to make that decision with the input of others and then also the patient. And when you're working there as a family, as peers, you are taking responsibility. And remember, you're coming there with your professional ethics. So it is possible for presumptive treatment to be done for some cases. It has happened. And even there are some decisions that doctors make in regard to this could be the worst case scenario. So we are willing to err in this way because of ABCD factors. So having an opportunity to sound with your peer would be very important. And if it is especially a team, even the better. So I cannot fully comment about that specific case, but just to say, it is possible to have delayed diagnosis, even when you're in a system, and it is possible for presumptive treatment decisions to be made by a team of doctors. But that should not be done without the involvement of the family. And so the family also will need to be given the rationale for the decisions that are being made. So most of the time you'll hear them clearly say these were the basis for this decision, and they are unlikely to sue if you work with them. Communication is usually the break of most of these difficult situations, but the at risk procedures or at-risk related diagnosis, there's a way in which at times you don't have much time, but you have to make it right. Some places have developed checklists. So once you do not meet this criteria, or once you meet this criteria, you are unlikely or likely to be like this. It helps you to make more comprehensive differential diagnosis and options of care. Thank you.
All right, thank you so much. So as we try and wind up this very productive discussion, I would like the panelists, I would like to thank you for your time. Thank you so much, Mary, for being so brave and sharing your story and teaching us, being our teacher today. You know, we've managed to hear from the patient's perspective. We've heard about all the factors that you faced. We've heard your story, and we have learned how we can improve our system so that other patients like you don't go through the same thing. And thank you so much, Dr. Okutoi, for shedding light on diagnostic safety in general, how we can understand it more, how we can make it better, how we can improve it. So to each of the panelists, what would your parting shots be to our audience today? We can start with Mary.
Because this is mainly medic driven, I think listen to your patients. A lot of people don't have time because I mean, you're seeing 15, 20, 30 people, so you want to rush the process. But listen to your patient, listen to what they have to say, listen to their fears and their concerns, because those form part of the healing process. It doesn't hurt. You inconvenience the others, but for a little bit. I think that's what I can say. For everyone else, if you get a family member or a friend diagnosed with a critical illness, please don't cry, at least in front of them. It does not help their healing. Go and cry elsewhere. Be strong for this person, be available, offer to help where you can, drive them around, get them fruits, get them help, pay for someone to clean their house and stuff like that. But do not offer medical advice if you're not a doctor. I think that's what I can say.
All right, thank you very much, Mary. We shall keep that in mind and try to listen better. Dr. Okutoi, what would you say to us as a parting shot?
Yeah, first of all, I just want to appreciate Mary for being here and giving us a lot of insights. I think my parting shot is in relation to engaging the patients and the family. The picture I showed of a pilot wondering why a mountain goat is in the cloud. When we listen to the patients, they're the ones who come with the symptoms, and the symptom is clouded with, there's a lot of noise and some signals. So when we listen to them more and when we are present, then it is likely for it to set the stage for the correct rollout of the next steps and next tests that are required. And even when we're in the middle of all those and they're not making sense, coming back and listening, hearing how they're feeling and correlating it with the tests will help us get more situational aware, understand the context, and it will reduce our bias, and it will help us get a more accurate, timely, patient-centered, and a diagnosis that helps address the problem the patient is having, because things unfold. But let's put the patient at the center of this. The rest will reorganize. It will give us the direction of what next and what else. Thank you very much.
All right, so that brings us to the conclusion of our webinar. And this was improving diagnostic safety and hearing from our patients. This is a follow-up to the World Patient Safety Day, which was commemorated on Tuesday, and the series will continue. And we have other webinars in this patient safety series. I apologize, we haven't gotten a chance to answer all the questions, but thank you so much, everyone, for your time. I do believe that these discussions have been insightful and edifying, and yes, we hope to see you at the next webinar. Mary also says that she is trying to publish her book, and I think it would have pointers that we can all learn from. I think we can sidebar to see how we can better support you, Mary. So thank you so much to all of you, and have a lovely afternoon.
Michelle, before we go,
Yes.
I am available for questions outside of the session. You have my email address, you have my phone number, please.
Yes.
Anyone, I mean, the journey is very daunting, and if you have support of any kind, it helps. It goes a long way. So anyone who is a caregiver, anyone who's a newly diagnosed patient, please feel free to avail my info, and then I can help them navigate it's actually a journey with speed bumps and potholes. So I call this my speed bump, on the journey that is life. So we are here to help people navigate their own speed bumps and potholes.
All right. Thank you so much for that. In case anyone needs to get in touch with Mary, kindly let us know, and we will link you guys. Thank you so much, and that brings our meeting to an end.
Thank you.